Hi, my name is Valerie Mitchell, and I am doing my presentation on multiple sclerosis. Our objective of this slide is to teach you about MS, which is a demyelinating disease of the central nervous system. In this presentation, we will discuss impact on the population, etiology and risk factors, pathophysiology, clinical manifestations and complication, treatment options, and nursing evidence-based practices. Impact on the U.S. In 2021, the incident was 9,300 new cases per 100,000. The prevalence in 2021 was 1 million persons, usually aged between 20 and 40. The figure here shows that in 2025, the northern states had 377 cases per 100,000, Midwest states had 353 cases per 100,000, and the southern and western states had 277 cases per 100,000. In 2021, there was 757.44 deaths related to MS in the United States. In 2021, the individual cost for MS patients was $65,612 higher than a patient without MS, and it mostly came to disease-modifying therapies and caregivers. In 2021, economic U.S. cost was $85.4 billion, which was also related to disease-modifying therapies, loss of productivity in jobs, and caregivers for these patients. The etiology and risk factors of MS. The etiology of MS is unknown. We do know that MS is not contagious. It is an autoimmune disorder when the body attacks the white and gray matter of the central nervous system by breaking through the blood-brain barrier. It is believed to be a combination of genetic and environmental factors and the abnormal immune response. It is not hereditary, but there is a higher risk if a family member has MS. Risk factors are shown here in figure 2. Sex actually is a big risk factor, with females being 3 times more likely than males to develop MS. A first-degree relative gives you a 2 to 5% increased risk of developing MS, and children of MS parents have a 10 to 20 times increased risk of developing MS. Identical twins that are diagnosed with MS, the other twin has a 25% chance of also developing MS. Race is a risk factor for developing MS also, with Caucasians having a higher incident. African Americans have a lower incident, and Hispanic and Asians have the lowest incident rate. African Americans that do get MS do have more issues with vision and mobility. They tend to be diagnosed older, and they have more progressive forms of MS that tend to, for some reason, respond less to disease-modifying agents. Smokers are also a risk factor where they have more progressive forms of MS, and women that smoke are 1.6 more likely to be diagnosed with MS than women that do not smoke. Low levels of vitamin D and less exposure to sunlight are also associated with an increased risk of MS. The Epstein-Barr virus is a risk factor and is believed to trigger the immune system response. Childhood and adolescent obesity increase a person's risk of being diagnosed with MS also, and there is a correlation with a high BMI and a more progressive form of MS. Having another autoimmune disease also puts you at more risk of getting MS. Pathophysiology of multiple sclerosis. Multiple sclerosis is a central nervous system autoimmune inflammatory disease. In MS, the immune system activates a response which then activates the T and B cells. They are able to pass through the blood-brain barrier by connecting with adhesive molecules to get into the central nervous system and attack the myelin. The myelin sheath is the protective covering over the axons or nerve fibers of the central nervous system, and it allows the nerve signals to travel quickly. Figure 3 here shows us that there is what a normal myelin sheath looks like, and one that has been damaged by the T and B cells. Once damaged, as you can see in the figure, The axon is exposed and the nerve is no longer able to properly send signals. The T cells attack the oligodendrocytes, which maintain the myelin sheath. As they die, the sheath will break away and cause demyelination. The B cells produce antibodies that mark the myelin sheath to be attacked by other autoimmune cells, which can also destroy and cause demyelination. Astrocytes from scars in the areas of the myelin sheath that have been attacked are called plaques or lesions. This affects the nerve's ability to conduct its signal. This causes the axons to be damaged. It blocks the nerve signal and leaves permanent scars which impair nerve conductivity. The attack on the myelin sheath causes cortical atrophy, cerebral cortex shrinkage from the neuron cell death. Clinical manifestations and complications. MS can be classified into 4 different types: clinically isolated syndrome, relapsing remitting MS, secondary progressive MS, and primary progressive MS. The clinically isolated syndrome is a single attack that is shown on an MRI. It usually is fully resolved. It doesn't leave deficits. The relapsing remitting MS is the most common. It is defined relapses with partial or total recovery and periods of inactivity in between these attacks. They could last weeks, months, or years. Secondary progressive MS usually starts as relapsing remitting MS. It is a steady progression and deterioration of the central nervous system with these defined attacks. And primary progressive MS is less common, but it doesn't really have defined attacks. There's just a worsening of the neurological system from the very first attack. Our figure here does show how MS may affect different parts of the body. It could be vision changes, which are double or optic neuritis. The spinal cord could be involved with a positive Lermont sign, which is the electrical shocks when you put your head down. The senses can be affected with tingling, numbness, and weakness of an arm, leg, or trunk, or even spasticity of our muscles. An MS hug can be reported when there is a band sensation around a patient's chest. Cognitively, they could be affected with fatigue, memory difficulties, or cognitive concerns, and speech can also be affected. The urinary system is usually affected a lot too. Diagnostic testing includes McDonald criteria, which is the international guideline for neurologists. It includes MRIs, evoked potentials, and lumbar puncture testing with spinal fluids. We're looking for proteins in the spinal fluids, inflammatory cells. With evoked potentials, we're looking for prolonged latency in between nerve signals. MRIs are usually of the brain, cervical, and thoracic, and we are looking for these lesions. Treatment for MS includes suppressing the inflammatory response of the disease by using disease-modifying therapies. It is also important that we also treat any kind of acute relapse with IV corticosteroids to suppress the immune system and reduce inflammation to prevent permanent lesions. And we also must help our patients take daily medications to increase their quality of life. The 2 medications I've looked at are Tysabri and Ocrevus. Tysabri is a monoclonal antibody. It is infused every 28 days over 1 hour. PML is a huge concern with Tysabri, and patients must get their JC virus level tested. And it does this by preventing B and T cells from entering the blood-brain barrier. Ocrevus is also a monoclonal antibody. It treats all forms of MS, but it also treats primary progressive MS, which most do not. It is 2 loading doses within 14 days and then every 6 months. Its infusions are a little bit longer, and it targets B cells and destroys them. There is also an increased risk of infection related to the destroyed B cell. Nurse evidence-based practice. I have gone to Nurse Together and read an article on nursing diagnosis, care plans, assessments, and interventions regarding MS patients. Nursing goals. We need to limit the disease progression, provide sympathetic relief, manage neurological deficits, teach our patients about their disease-modifying therapies and also how to recognize MS attacks. Nursing care plans should include impaired physical mobility, impaired urinary elimination, risk for infection, powerlessness, and fatigue.